Very good afternoon to everyone, and thanks, Rohit, and of course, congratulations for yet another edition of the Lenticule Congress. And as I can see, when I walked in today morning, the hall was full and there was no place to sit. So it's been a really interesting 2 days so far. So I wanted to speak on Smile Xtra and how we've gone through our experiences with Smile Xtra. How many of us here are doing lenticule surgery already, and so I'm sure there are lots. And how many of us are actually doing extra procedures with lenticule surgery? So there are a few people, right? So we all understand, we are all here because lenticle extraction has become increasingly popular over the years, and it offers all these things which we all understand, and I don't need to repeat them. And again, this slide has been shown time and again, and it just goes on to show that all manufacturers are now into the game of doing lenticule surgery. And we also all understand, all of us who do refractive surgery, that there is corneal weakening with refractive surgery when you do it on the cornea because of many reasons, and that's why we've evolved towards the lenticule from doing flap-based surgeries because of the vertical and horizontal delamination cuts and tissue subtractions, Bowman's injuries, and other factors. All surgeries have a system of weakening the cornea in one way or the other. And we also now have better understanding of what are the risk factors. We have younger patients, high myopia. Our limits of correction have come down drastically from the time I started doing refractive surgery about 20, 25 years back. And our better understanding of topographies and corneal biomechanics, and also with Damien Gatinel's emphasis on eye rubbing. And we all now actually are very conscious about this, not only for choosing our patients with keratoconus, but also with post-LASIK and post-smile ectasia. We've seen this being a very, very important factor as well. And then again, the big debate about the residual bed. So going on, there is a reason for choosing extra procedures, and many people have been working in various ways. This was a review which was done for refractive ectasia after corneal refractive surgery of various kinds, and they went on to study many of the case reports and studies which had already been done. And some of the key summary points were that following PRK, there is a risk factor of, there's a 20 per 100,000 eyes report of ectasia. With LASIK, that becomes almost 90 per 100,000 eyes. At the time of publication of this study, it was, for SMILE, it was only about 11, but that's because there were much lesser number of total patients who had undergone SMILE with much shorter follow-ups, probably. So as it is only understandable that ectasia was found to be 4.5 times more likely after LASIK than with PRK. And although SMILE does appear to have the lowest rate of ectasia, but over time, and especially now that we are doing huge numbers of lenticules as compared to other procedures, we will probably have more reports. And yes, ectasia does happen after lenticule extraction as well, but it seems to be, we are improving at diagnosing and also not treating those patients, but maybe also doing the extra procedures. So is there a need for extra procedures? Simultaneous cross-linking has been proposed as an adjunct therapy to prevent future ectasia. And all these procedures, as we understand, do cause biomechanical instability. And with the risk factors like the thin corneas, the higher myopias, and the abnormal topographies, and eye rubbing, they do give you an kind of reason to cross-link as well. So there have been lots of publications and work done for LASIK Xtra, especially Canalopoulos did a lot of work with that, plus a lot of others, including Theo Seiler. There were also lots of studies with PRK Xtra, and they have been practiced over the last 15, 20 years as well. And with SMILE also, there have been, and of course, now I should probably say about KLEX. We do have several publications, and these were, most of the inclusion criteria were for patients who were at higher risk of ectasia, and I've spoken about them a few times already. So the efficacy of the KLEX plus procedures or the KLEX Xtra procedures, they have shown that the CXL may not have a significant impact on the uncorrected visual acuity when it is combined with SMILE. And then another study done by Sri Ganesh et al. Also gave out good results as far as the efficacy is concerned. Several of the studies also spoke about good safety profiles, and I will not go into the details, but a couple of them showed haze, but that also depends upon the amount of total energy that you use for the extra procedure. So overall, the safety was proven to be pretty good. Then again, as I said, the energy protocols have shown them to vary from as little as 0.8 joules per centimeter square to as much as 5.4 joules per centimeter square. And just like we are playing with energies for the lenticule extraction, we also are probably kind of working on this aspect as well. But the accelerated protocol is considered as the better way because it may not cause the excessive flattening as you might see otherwise with cross-linking, which we've been doing over the years. Also, a lower UV energy may reduce the severity of the potential complications like haze, etc. So this was a benchmark study which was published by Sri Ganesh's group, and they actually studied, they included patients who were meeting any of these 3 or more criteria with corneal thickness less than 480, a residual bed of between 250 to 280, and refractive errors of greater than -6. Pentacam criteria of bad D values more than 1.65. They were using Corvus also over there with the CBI and TBI more than 0.5 and 0.29, and some other additional risk factors like age less than 30, a family history of keratoconus, history of eye rubbing, etc. So if you had more than 3 of these parameters, they selected, and they had a very interesting result here. Out of the total number of eyes of about 7,000 eyes which were treated, SMILE was done on about 6,000 of them, and 2 of them went on to develop ectasia. They qualified the eyes which met those parameters as borderline eyes, and half of them underwent SMILE Xtra and the other half underwent SMILE. So the SMILE eyes went on to develop ectasia in about 8 out of these eyes of 594, and none of the eyes with the Xtra group actually went on to develop ectasia. So at our center, we've been doing SMILE Xtra for about 5 years now, and we started doing SMILE almost 8-9 years back, but we started delving with Xtra in a very small way. We use 0.23% riboflavin, diffuse it for 60 seconds in the interface, and then we do a 90-second protocol with the 30 milliwatts. That's what our machine permits. This is the riboflavin that we've been using. So you cannot use the conventional riboflavin for risk of doing causing interface inflammation. So once your lenticule is out, you have to just put it in the interface. And then, so you should not actually put it on top of the cornea. You should only put it in the interface, because when you put it on top of the cornea, you're actually blocking some of the UV from going in. And then you can easily cross-link it for about 90 seconds. And this is a standard cross-linking. It's a flash cross-linking. So going on, post-op regime is, you may expect a little more inflammation and haze in the initial days. So we use 4 weeks for these patients for topical steroid. And in 5 years, we did about 94 eyes of 50 patients. And we use the same selection criteria except for the Corvus, which we don't use, as from Ganesh's study. And we did not have a control group because, most of these eyes which were chosen for SMILE Xtra were not, it was not ethical to actually put them into ICL and for the SMILE itself, because otherwise they were offered an phakic lens. So this was the laterality, which is not a big deal. Age was, all of them were over 20 years. And this is the axial length, which I don't think carries huge importance. Now, coming to the preoperative spherical equivalent, this is about -6, and you can see that the astigmatism is not very high here, and the post-op spherical equivalent was -0.07, which was the average, so it does pretty well. This is the distribution of the preoperative and postoperative pachymetry. So again, this is for another day, because I'm going to be out of time soon. This is the visual outcome, and it looks pretty good over here with almost ±0.25 and 37% and 92% eyes meeting ±1. And here I must say that because we were treating a few patients with higher corrections, we did undercorrect a couple of these patients. We may not have offered them a full correction. That may contribute to this as well. And we did have patients meet good, so I'm going to finish in 30 seconds. So our 55 of these, 64% patients met their best corrected vision, uncorrected vision as 6.6, and almost all were 6.12 or better. Loss of lines from pre-op BCVA to post-op uncorrected visual acuity, again, we did a great job with that as well. So it looks good. Here we wanted to point out just one thing which we saw. The epithelium healing in SMILE Xtra and SMILE, conventional SMILE is slightly different. So on SMILE, as you can see here, this is the preoperative, and then this is the response at about day 21 and at 1 year. And if you look at SMILE Xtra, typically the epithelium response is little less. So this is day 0, this is day 21. And you'll see that this never catches up. So this is the pattern that we've seen almost in all of our patients that we do SMILE and SMILE Xtra. So our results have been fairly good, almost no refractive surprises with very good long-term stability. And maybe it may take about a week or two longer for visual stability, but eventually they do quite well, and complications have been minimal. And how it adds to our armamentarium is that we are able to offer this patient surgery to patients who are otherwise unfit for maybe phakic lenses because of very short AC depth and may not be fit for any kind of laser correction surgery. Slightly suspicious corneas who may not qualify as keratoconus, also eye rubbers, we offer SMILE Xtra who meet those criteria. And since their safety and efficacy matches SMILE, it allows the surgeon to sleep well and the patients to be more reassured about the safety of the procedure. And so I think this has a role, definitely, extra procedures. I don't like to do PRK extra unless I'm doing topo guided, and I do offer Smile Extra to these patients. So it shows promise as a safe and effective option, and I would love to discuss with others if they have any thoughts on this. Thank you.